So first we'll talk about pleural effusions. So what is an effusion and why is it formed? So we know Starling's forces wherein we have an hydrostatic pressure and an oncotic pressure. So we know that there is going to be increased pressure in the pleura that is going to cause um, formation of the pleural fluid. So you have your net driving pressure. So the parietal pleural pressure will be more than the visceral pleural pressure. So the net driving pressure is about 6. So because of which we are going to get pleural effusion formation. So we'll discuss on three main disorder. One is effusion, pneumothorax, and empyema. So if you see why is the pleural effusion formed, it is a combined effect of your net hydrostatic pressure and your oncotic pressure. So normally your hydrostatic pressure will be more. If your hydrostatic pressure is more, it will make the fluid go inside the pleura, and the effect of your oncotic pressure would be it will try to retain it in the pleura itself, in the blood itself. So it will prevent formation of the fluid. So when you're combining these two, if the net effect of hydrostatic pressure is more or if the oncotic pressure is less. So these are the only ways you can get a pleural effusion. Or you have the permeability through the membranes of the pleura through which you are going to get a formation of the fluid. If the permeability increases, so this is a constant factor that is there. So this is where you can get your effusion. And normally the formation of fluid is about 0.26 ml per kg. May be asked, may not be asked. So it has been asked in the previous years. And the absorption is 34 to 700 ml per day. And if you see normally, uh, this hold good at any point. So if you have, this is the arterial end and this is the venous end. And you are going to have a communication between the arterial and the venous end. So normally the arterial pressures will be more and the venous pressure and the hydrostatic pressure will be less. So thereby you are going to get some gradient of the fluid that is going to go out. So this fluid that is going to go out will go either to the interstitium or it will go to your lymphatics. So normally you are going to have your lymphatics or your interstitium. So let us say there is a condition wherein you are going to have very high venous pressures or there is very high lymphatic pressure. So then your pressure is in the hydrostatic pressure will become more and you're going to get more of the third spacing. So this is where you'll start getting effusions. So you may get it in the pleura, peritoneum, anywhere you can get. So all of this is because of the simple fact that your pressures in some compartment is altered. Okay. And if let us say this is one more important thing you remember is this lymphatics that are there, especially in the pleura. So it is almost 10 times of normal. So almost whatever is going to be absorbed. So the lymphatics have 10 times more of what is normally being produced, being absorbed there. So that is how efficient lymphatics are. So if you're going to get an effusion because of a lymphatic obstruction or in per se in pleural effusion, so that has to impair the lymphatic significantly. So that is one thing that you should remember. So the flow depends on your Kf is their permeability factor and the combination of your pressure difference and your oncotic pressure difference. And so once you have a pleural effusion formation, so what are the clinical features that you're going to get? So clinical features would be you will have dullness on percussion. So if you use an evidence-based examination, percussion has the best evidence. Apart from that, you're going to have a reduced movement. So these are the only two things that you're going to get in clinical feature. The other thing that will be there, this is very, very crucial, is there going to be a presence of hypoxia? So even when you have a bilateral pleural effusions, even when you have a unilateral or bilateral pleural effusion, presence of hypoxemia is very, very rare. So whenever you have a pleural effusion with a hypoxemia, presenting any acute respiratory failure presenting with hypoxemia, even though you have a pleural effusion, think that there should be some other underlying cause for this hypoxemia rather than just the pleural effusion alone. So this is a key takeaway that you should remember. So the pearl would be any hypoxemia with an effusion is not due to the underlying effusion and due to some other cause unless proven otherwise. So this comes from a lot of data. You have a long-term data of about 200, 300 patients where they saw in the emergency that not even one patient who presented with bilateral effusions or unilateral effusions had any hypoxemia. So that is important to note. So we'll see the etiology, we will see in the workup. And how are you going to evaluate pleural effusions? So traditionally what is thought is you will see an effusion, you will tap it, you will say whether it is exudate or transudate, and then you will go on evaluating. But rather you change the gears and think history would be determining what is the center of gravity. So what are the clinical symptoms? That will drive what could be the underlying cause of this effusion. So that is very, very essential. If you don't have a pretest probability of what could be the cause of the effusion, then you will be blind and you will do unnecessary investigation as well. So history would be the center of gravity. So you're the center of gravity. And you will use an imaging. So what are the imaging modalities we have? Chest X-ray, ultrasound, and CT, plus or minus PET scan. And you have thoracocentesis and a biopsy. These are the only tools that we have in the armamentarium to get to the etiology. So how do we understand what are effusions? So this depends on how the pleura is. So if the pleura is 100% non-permeable, then it has to be only blood. Whereas if the pleura is 100% permeable, so in the sense, if the pleura is 100% permeable, that means the junctions are completely normal. So what I mean to say is the junctions between the epithelium are preserved. So if this is preserved, that means the only fluid that can go out is a transudative fluid, or it will just be a watery fluid. So you can put it as a watery fluid. Whereas if something else has to go, that means the pleura has to be more permeable. So depending on what is the permeability, if it is 100% permeable, that has to be blood, because whatever is going to go will be going from the blood cell and then onwards. So if whatever is there in the blood is completely going inside, that means there is no space at all. So everything is going inside. So it is 100% permeability. Whereas only few substances are going. That means it is going to be an exudative substance. So if it is an exudative substance, you can have proteins, you can have cells, you can have so many things that can pass through the pleura. So that is what we call as inflammation. So there is pleural inflammation. So if you want to see how leaky it is, so the only way you can get it is by using a contrast. So you use a contrast, so you will pick up whether the fluid is leaky or not. Next, how are we going to evaluate a transudate? So if it is no permeability, it is going to be a transudate. So if it is a transudate, so it is non-protein rich fluid. Non-protein rich fluid. So this is how we should think of it. Non-protein rich fluid. So we saw in the Starling's law, either there is increased hydrostatic pressure or there is a low oncotic pressure. So if there is a very low oncotic pressure, that means the protein in the fluid is very low. So this protein, so there are some endogenous substances which have a low protein by themselves. There are two things, which is CSF and urine. So if you have a CSF, it is called as a, so commonest cause for a CSF leak would be a uropleural fistula. Very rare, usually it is post-surgically you will see. Other thing, you can have a urine that is completely going to be having low amount of protein. So it is going to be having high creatinine and low protein. So that is what you're going to see in a urinothorax. So this is what is called as a urinothorax. So if you think why is the urine going to come from the urinary bladder and from formation to the pleura, how can it come? So there are only two ways in which it can come. So if you say this is the abdominal cavity and this is the pelvis cavity, so either there is a urinary ascites. So if there is a urinary ascites, let's say there's a bladder rupture and there is a urine in the ascites, that can track into the pleural cavity. This is one way. Other way is something like a trapped lung wherein there is a very high pressure in the lung and it just sucks the fluid. So then it is through the lymphatics it will go and go and drain into the pleura. So this is your urinothorax. How are you going to diagnose urinothorax? You take the pleural creatinine divided by serum creatinine. If the value is more than 1, it is going to confirm that it is urinothorax. So how are you going to treat? Treat the underlying cause. That's all. You do a drainage, you see why is it coming, and then you can treat it. Or what you can do is if there is a diaphragmatic opening, so what you can do is a diaphragmatic repair. So this is how you will treat it. Either you can do a diaphragmatic repair or you drain it. If it is in the ascites, etc., you can drain. Next. Exogenously, how can you get? There's a low protein fluid that you're giving from outside. How can you get, let us say there is a central line that is communicating with the pleura. So inadvertently you hit the pleura there. So then it can happen. Or peritoneal dialysis fluid. Very common whenever you are having a dialysis patient. Very, very common this is. In the current era, peritoneal dialysis is very much upcoming. And most centers are doing a peritoneal dialysis. So this is very, very common cause of a protein low fluid. Next, you can have venous hypertension, which can be systemic or local. So systemic cause of a venous hypertension would be 3 causes. Cardiac failure, liver failure, renal failure. In cardiac failure, usually the effusions are bilateral and small with an associated enlarged heart or cardiomegaly. Liver failure, usually it is going to be right-sided in about 85% of the patients. Left-sided effusions you can get in 15%. So whenever you have it only on the right side, you call it as a hepatic hydrothorax. Okay. So whenever you have hepatic hydrothorax, how are you going to manage? We'll quickly see this here itself. So hepatic hydrothorax, you are going to do a drainage. Okay, you can do a pleural thoracocentesis. Never try to put a chest tube in these patients. You just do a thoracocentesis and drain as much as possible and treat the underlying cause. Treat underlying cause. So this is with respect to your liver failure. So if sometimes you may not be able to do it. So let us say sometimes there is a refractory cause. So then you treat like a large volume paracentesis you add a diuretic, you add other substances, the vasoactive substances. Despite that it is not improving, then you can do a TIPS. But problem with TIPS is it can worsen your hepatic encephalopathy. So if you're having a liver failure patient, tipping him into a HE is very dicey. So what you do, the other option is, although the evidence for this is not very great, there are very few case series and reports that are there. There's a consensus paper that is there. You can do an attempt of an IPC. You will see what is an IPC in the subsequent slides. So this is what is called as an indwelling pleural catheter. So you'll have a catheter inside the pleural space and you can drain whenever you feel like draining. And plus minus, you can do a talc pleuritis. So when you're putting a catheter, put a talc agent. Once the lung is expanded, and you can use this. Whereas there is high risk of infection of the pleural catheter also. This is one thing that you should remember. Then you have renal failures. So in renal failure, very interestingly, you can have in 2 ways. So it can be a transudative or it can be an exudative. Exudative, it is because of a uremia. Transudative, it is because of your volume over. So both can be there. So it is very important to distinguish these two. Next. Local cause, you have pulmonary embolism. Very important. 15% of pulmonary embolism can come with a transudative effusion. That is because of your lymphatic obstruction. And whenever you have a unilateral effusion, which is transudative, and patient is still hypoxic, you have to rule out a pulmonary embolism unless proven otherwise. So that is one poll that you will take back. Hypoxemic unilateral transudative effusion is P until proven otherwise. Next, you can have SVC syndrome and dialysis access related. So this dialysis access related is a very interesting phenomenon. So when you have a dialysis access related effusion, so usually it is going to be left more than right. Usually it is because of a AV fistula. So when you have an AV fistula, you have an arterial end, you have a venous end. When there is constant high pressures, your arterial pressure will be more. So thereby you are going to get an effusion. So why you are going to get this effusion? Normally, if you are going to connect arterial vein, so it is going to flow normally. So whereas when it is chronically happening, sometimes you may get some blockages. So once this blockage happens, your pressure will increase and you're going to get an effusion. So what will happen is, because of this block, the proximal end, the flow will be very high. So normally your pressure will be, the flow across the fistula will be 300 to 1500. If the pressures are more than that, if the flow rate is more than that, so you can get it pick up on a Doppler signal. You just put an ultrasound, you'll get this flow. You just put it, you will get a flow. If the flow rate is more than 1500 with a unilateral transudative effusion, which is predominantly on the side of the dialysis axis, you can diagnose the set as a dialysis axis catheter related effusion. And once you close the dialysis axis, so when will you close this? You go for a transplant, you will close the dialysis axis catheter. So you'll, once the graft has matured and the stable renal function is there, you'll close the dialysis catheter and the effusion will resolve. So this is dialysis access related effusions. Sometimes you may not understand why the patient is having effusion. So this is one of the causes in renal failure patients. So apart from that, you have your dialysis access related catheter. Okay. Then you have trapped lung physiology. What is trapped lung physiology is? So let us say you have a lung, and in this lung, what is going to happen is there is an endobronchial disease. So if there is an obstruction endobronchially, so it will not allow the lung to expand completely. If you're not allowing the lung to expand completely, what can happen is there is going to be an accumulation of the fluid in the pleural space because of the pressure difference. Pressure gradient will be there. That is one way. Or you can get a visceral pleural disease. So wherein there is going to be a pleural thickening and a pleural peel formation. So when that occurs, that also can cause a effusion. Okay, so that was about transudative. So we have seen dialysis access related. So next we have your trapped lung physiology. So if this is my lung and this is the pleural covering that is there. So if there is a thickening of the pleura, so it will not allow the lung to expand. So if it is not allowing the lung to expand, there is going to be a high pressure in the pleural. So the pleural pressure will be more. So thereby you are going to get a trapped lung. So or it is like a lung is inside a cage. So this is called as a trapped lung. Next, you have an endobronchial disease. So wherein if there is a tumor that is obstructing here, so you're going to get a lung collapse. So this lung is going to collapse and you're going to get a passive fluid formation. So here also, once the lung collapses, the pressure here will be more and it will secrete it here. So this is going to be your trapped lung physiology. Next. How are you going to evaluate, especially if it is an exudative effusion? Okay, so if it is a transudate, it is a protein low fluid. So how are you going to say it is a low protein or a high protein fluid? So this is based on your Light's criteria. So what did Light say? He was an intern and he gave this criteria. So what he said was, he said you use the pleural protein. So simple logic, he just said permeability is there or not. So if the pleural protein divided by serum protein is high, or if the pleural LDH by serum LDH is also high, then you can say it is exudate. So this is what he gave. So we'll see subsequently. So this is, if it is positive, it is going to be an exudate. Otherwise, it is going to be a transudate. So if it is an exudative effusion or any effusion, so you will use a history. You